Audio course on cervical shortening during pregnancy. Episode 2, Measurement and Risk Interpretation. In the last episode, we built the core model. A short cervix is not one diagnosis. It is a risk signal embedded in context. In this episode, we focus on the first step before any management decision. Make the measurement trustworthy. This sounds basic. It is not. Many wrong decisions in cervical shortening start with a number that should not have been treated as a decision-grade number. The dominant model for this episode is simple. Measurement quality comes before management. If the cervical length is not measured correctly, the downstream decision can look evidence-based while being built on sand. SMFM recommends that cervical length measurements used to guide therapy be performed transvaginally and according to standardized procedures. Gabby makes the same practical point. Transvaginal ultrasound is the clinical standard for treatment decisions. Transabdominal measurement can be useful as a screen or as part of a routine anatomic survey, but it should not be the final basis for major therapy when the cervix appears short or is poorly visualized. Why? Because transabdominal ultrasound can overestimate cervical length. It can miss a short cervix. It may require a full bladder, which can artificially elongate or distort the cervix. Fetal parts can obscure the view. The image quality may be inadequate. And the thresholds from the key trials are based on transvaginal measurement, not casual transabdominal impressions. So the resident reflex begins here. If the cervix looks short on transabdominal scan, confirm it with standardized TV ultrasound before making treatment decisions. Now let us talk technique. The patient should empty the bladder. The transvaginal probe is placed in the anterior vaginal fornix. The operator should avoid excessive pressure because probe pressure can artificially lengthen the cervix. A useful technique is to withdraw the probe until the image blurs, then reapply only enough pressure to regain the image. The cervix should occupy most of the screen. The internal os, external os, and entire endocervical canal should be visible. The anterior and posterior cervical lips should look similar in thickness, which helps confirm that the probe is not compressing the cervix. The closed portion of the canal is measured from internal os to external os. Usually more than one measurement is obtained. The examination should not be rushed. Fundal or suprapubic pressure may be used to assess dynamic shortening or funneling, while reducing probe pressure so the cervix is not mechanically held closed by the transducer. The point is not that every resident must personally perform every scan. The point is that every resident must understand what makes a cervical length actionable. If the report says cervix 22 millimeters, ask yourself, transvaginal or transabdominal? Empty bladder? Adequate view? Closed canal measured? Any funneling? Any dynamic change? Any membranes? Any symptoms? Now the hardest conceptual piece. 25 millimeters is not magic. It is a useful clinical threshold because it approximates a low percentile in the mid-trimester and because trials and guidelines need boundaries. SMFM uses a mid-trimester transvaginal cervical length of 25 millimeters or less to diagnose short cervix in a singleton gestation without a prior spontaneous preterm birth. But cervical risk is continuous. The classic IMES study showed a steady inverse relationship. As the cervix shortened, spontaneous preterm birth risk rose. At 24 weeks, cervical length less than or equal to 26 millimeters carried a relative risk above 6 for spontaneous preterm birth before 35 weeks, compared with the longest cervix group. The risk rose further at lower lengths. Less than or equal to 22 millimeters had higher risk. Less than or equal to 13 millimeters had much higher risk. So do not teach 25 millimeters as a cliff. Teach it as a decision threshold placed on a slope. This explains several clinical behaviors. At 26 millimeters, the patient is not biologically risk-free. At 25 millimeters, she does not automatically need every possible treatment. At 18 millimeters, risk is higher than at 24. At less than 10 or 11 millimeters, the question changes again because occult dilation becomes more likely, and SMFM notes that cervical examination should be considered. The next concept is population. The same cervical length does not mean the same thing in every patient. Imagine a TV cervical length of 23 millimeters at 21 weeks. In a singleton with no prior spontaneous preterm birth, this is short cervix in a low baseline risk population. The positive predictive value is not high. Many of these patients will not deliver early. The question is usually vaginal progesterone discussion, not panic. In a singleton with a prior spontaneous preterm birth, 23 millimeters means something different. The baseline risk is higher. The probability that the cervix is part of a recurrent spontaneous preterm birth pathway is higher. Serial surveillance, progesterone strategy, and possible cerclage discussion become more important. In twins, 23 millimeters predicts risk strongly, but treatment evidence is less certain. This is the trap. Good prediction does not guarantee effective prevention. In a symptomatic patient with contractions, cervical length becomes a short-term risk tool. A long cervix is reassuring. A short cervix increases concern, especially with fetal fibronectin or progressive change. But now you are not simply doing prevention, you may be triaging threatened preterm labor. In a patient with painless dilation, the cervical length number may no longer be the main issue. Physical exam findings and membrane status may dominate. So the resident reflex is this: never interpret cervical length without the denominator. The denominator is the patient population. Let us turn to gestational age. The mid-trimester matters. The major prevention framework is built around roughly 16 to 24 weeks. Local routine ultrasound workflows may include cervical assessment in the 17 to 24 week period. Many trials enrolled around 19 to 24 weeks. SMFM prevention recommendations for no prior spontaneous preterm birth focus on diagnosis before 24 weeks. After 24 weeks, a short cervix still matters, but the clinical question may change. You may be estimating preterm birth risk. You may be deciding steroid timing if delivery risk becomes high enough. You may be triaging contractions. You may be deciding admission or transfer. But the clean prevention evidence is less direct. Now let us discuss funneling and dynamic change. Funneling can look dramatic. It often worries patients and clinicians. But management should not be based on funneling alone if the closed cervical length is not short and the clinical context does not support intervention. The reproducible, trial-based measurement remains the closed cervical length by standardized TV ultrasound. Dynamic change is real. The cervix can shorten with fundal pressure or over time during the exam. It may add concern, but it does not replace the need to classify the patient. Now, a bedside example. A patient is referred because the anatomy scan reports cervix 2.4 centimeters transabdominally. She's 20 weeks, singleton, no prior spontaneous preterm birth, no symptoms. The wrong response is to prescribe treatment immediately from that line. The right response is to confirm with standardized TV ultrasound. If the TV cervical length is 28 millimeters, she does not meet the usual short cervix threshold. If it is 22 millimeters, she does. If it is 8 millimeters, she needs not only a progesterone discussion, but also evaluation for dilation. Now, a second patient. 22 weeks, singleton, prior 30-week spontaneous preterm birth. TV cervical length, 24 millimeters. Do not say, it is only mildly short. In this population, prior history changes the meaning. The resident should think high-risk surveillance, current guideline options, and whether the patient is approaching an ultrasound-indicated cerclage discussion. The final idea is communication. Patients often hear short cervix and translate it into I am about to deliver. Residents need language that is accurate and not falsely reassuring. A useful counseling line is,
The cervix is shorter than expected for this point in pregnancy. That increases the risk of preterm birth, but it does not mean preterm birth is certain. The next step is to interpret the measurement in your specific situation, including your pregnancy history, symptoms, whether the cervix is closed, and how far along you are. That line does several things. It respects the risk, it avoids fatalism, it prepares the patient for individualized management. Let us close. The measurement episode has one resident reflex. Do not manage an unverified number.
Confirm the technique. Locate the patient in the right population. Treat 25 millimeters as a decision threshold on a continuum. And remember that cervical length predicts risk differently depending on history, plurality, symptoms, dilation, and gestational age. Once the measurement is trustworthy, management can begin.